All right, we are recording. Okay, so we're going to talk about fluid and electrolytes today. And we're going to start with fluid balance. So again, a lot of this you had last semester, so we're going to be doing a review of this because again, I feel like it's important enough to make sure that you understand the concept. So we're talking about fluid and electrolytes. We're talking about regulating extracellular fluid volume and intracellular fluid volume, as well as balance of your electrolytes. The fluid balance in your body helps with your circulation, helps with excretion, helps with absorption of nutrients. There's so many important things with fluid balance. So what we take in and what we put out helps to keep that homeostasis, that fluid balance that is that correct pH, the correct electrolyte balance, and the correct tissue. And we're going to talk a little bit quickly about removing that intracellular, extracellular fluid, how it moves through the body, and what happens if you have some deficiencies. Okay, so those are going to be some of the highlights. So obviously we want to keep optimal extracellular fluid. And here again, just reviewing the fluid shift, the intracellular fluid is what's found in the cells. Extracellular fluid is what's found externally around the cells in the tissues. 2/3 of your body is intracellular fluid. Okay, only about 1/3 is extracellular fluid. So most of the fluid that we take in is in the intracellular space, inside the vessels, in the cells, okay? Fluid volume, fluid balance helps to maintain our body temperature, helps to transport nutrients, helps to excrete waste. So fluids is very, very important. I would definitely review some of your A and P if it's something that you've struggled with. The beginning of the book talks a little bit about osmosis and cellular shifts and that stuff we're not going to focus on here. But if that's something you sort of like, oh, I don't really remember, it would be great for you to go back and review the anatomy and physiology. That will help sort of with the comprehension piece. Okay. All right, cool. So again, some words that we should remember is osmosis, brings things from lesser concentration to a greater concentration. Diffusion is intermingling the liquids, solids, and gases. Filtration is the movement of fluids and getting rid of things that are bad for you. And then active transport is moving things from intracellular to extracellular. So that's some terminology that I would review, okay? All right, so regulating body fluid. Fluid intake and fluid loss should be normally balanced, okay? An imbalance can result in an illness. So fluid volume deficit is usually when we have a decrease intake or an increase in output. So we're either dehydrated or we have a GI bug and we're stooling too much, right? So fluid volume deficit would be either a decrease in intake or an increase of output. When we talk about fluid volume excess, we're talking about an increase in intake. So maybe we're overloaded. So we can do that as nurses by giving someone too much fluid, right? Or we don't have enough output. So maybe we have some kidney issues where we're not excreting and putting out enough urine. So those are some of the things we're going to look at today. When we see insufficient fluid, again, we can see dehydration. With excess fluid, we see this edema, hypervolemia state, okay? Normal fluid intake is about 2,500 mLs per day, and that's at a moderate activity and a normal temperature. So obviously, if we were febrile, we would excrete more fluids, right? We call those insensible loss. And we're going to talk about what's insensible loss versus normal expected loss. Water content of food contributes. So if you eat vegetables per se, they're very high in fluid. And so those are help to give your cells nutrients and give your cells water. Okay. Our hypothalamus regulates our fluid intake. So again, we're always correlating with other organs. Our output is around 14 to 1,500 per day. We talked about in sim yesterday how we expect an adult to have at least 30 mLs of urine output every hour. That is the expected finding. So we would say in, a 24-hour period, around 14 to 1500 would be sufficient. We also have, again, sensible fluid losses. So we see that through sweat, through tears, things that are not measurable. So things that might, so even being tachypnic, breathing, we have water molecules that come out in our breathing, okay? So insensible losses would be anything that you cannot measure. Why these are important is because especially in kids, they have a higher risk of insensible loss than an adult does. So we can't just measure fluid volume deficit based on eyes and nose alone, okay? So we're going to talk about that as well today. Feces is also part of your output, and obligatory losses would be normal body function, so urination, things like that, all right? Sensible would be measurable, insensible would be unmeasurable. Any questions so far? This is all kind of review, right? You guys are following me? Good. All right. So consequences, alterations in fluid and electrolyte distribution, we get impaired perfusion. Remember, our blood can't flow if it doesn't have the volume to push the cells through the body. It also impacts our oxygenation because it impedes the way the red blood cells are transporting that oxygen to the body. So fluid volume overload and edema can happen. We also can have impaired cerebral function. So all of our organs require fluid to stay healthy and to perfuse and perform properly. So we could have decreased level of consciousness, which could lead to seizures, etc. It also can impair our neuromuscular function. So we can have weaker muscles, we can feel weak, we can have cramping in our legs. I mean, I don't know if there's any athletes or runners out here, but sometimes when you're running, if it's really warm, you can get a lot of leg cramps, and that's really due to the water leaching out of the muscles and being deficient in that fluid volume, okay? All right, so primary prevention. As nurses, we really need to make sure that we are on every patient, regardless of what their diagnosis is, regardless of what brings them into the hospital. We should always be monitoring ins and outs. We should always be monitoring for fluid volume deficit or fluid volume excess. That is a staple in our assessment, okay? So for example, somebody with heart failure, let's say they have a cardiac pump problem and they need to take medications to help diurese them. So they have heart failure, right? We know with heart failure, we can have extra volume, extra intracellular volume. And what happens is we need to give them a diuretic to help remove that fluid from the body. So by giving a diuretic, we are helping the body to maintain that homeostasis. However, we need to know, and we'll learn this as we go through the semester, that also giving a diuretic could also put them into hypovolemia, where we have excreted too much and now have caused a deficiency. So as nurses, we're always watching for those things. So just because it's not a diagnosis of fluid volume deficit or fluid volume excess, it could be a subsequent consequence of those. So we're always thinking about that with any patient that comes into the hospital, okay? Secondary, so that would be our primary prevention. What are they on? What did they get admitted for? How, are they nausea and vomiting? Are they having extra loss? Do I need to give them IV fluid? All of those things is our critical thinking and things that we need to be thinking about to help the physician make some of those decisions where they're not at the bedside. Secondary prevention would be screening, detection of fluid volume. So someone that's on diuretics, we want to check their potassium. We want to check their sodium levels. We know that they could pull too much potassium or sodium from the body, which could cause an electrolyte imbalance. So making sure that we're checking those electrolytes periodically so that we know that they are maintaining those as well. And obviously for health promotion, people that make sure they drink, make sure that they are, if they're exercising, they're increasing their fluid volume. that they are, taking care of themselves, healthy food, green leafy vegetables, fruits, etc. All of that is part of health promotion, which maintains homeostasis and good fluid balance. Questions about that? All right, so let's start with our fluid volume deficit. Okay, so when we think about fluid volume deficit, we immediately think dehydration, right? That's probably the most common diagnosis that we're going to see that correlates with fluid volume deficit. Those of you that did the VSIM know that Eva Madison was admitted for dehydration, and you guys, your job was to get her hydrated. So dehydration is definitely a common thing that we see in children for multiple reasons, in the elderly for multiple reasons, and often in adults when they have an underlying condition that causes fluid loss. So some of our risk factors, vomiting, diarrhea, GI suctioning. So if we have someone with an NG tube that's to low wall suction, we could over suction them. We could pull out too much fluid. And then if there's any intestinal drainage, so if someone has a colostomy or anything like that, that could be problematic. Other causes we mentioned already, diuretic therapy, heavy sweating. Okay, so if someone again is working out and it's 90 degrees outside or they're extraordinarily hot and they're not drinking enough fluid, hemorrhage, so bleeding, so post-operatively, we see that patient with the saturated dressing, that's fluid volume loss. Or maybe they had a very invasive surgery and they lost a lot of blood during surgery. Maybe they need some blood replacement. So that's something we think about. Chronic abuse of laxatives or enemas. Okay, so forcing ourselves to have extra volume loss. People use things like water pills and laxatives to lose weight and such. Those could be problematic. Inadequate intake. I have friends that just literally don't drink water. I'm like, guys, you gotta drink water. That's why you have headaches all the time. You're not hydrated. So making sure that we educate people, the importance, like our body is, I don't know, what is it, 60, 70% fluid. We need to make sure we maintain good fluid intake. Burns. We're going to talk a lot about burns this semester as well. We don't need to focus on it now, but when you lose that layer of skin, our skin's job is to hold in moisture. So when you get burned and you don't have that layer, we can have a lot of extracellular fluid loss. And fever. Fever is probably one of the #1 causes of insensible loss. Because when our temperature spikes, the body is dehydrating itself. It's trying to cool itself off, but because of that, our fluid volume is going down. So we want to make sure that patients that have fever, especially over a prolonged period of time, are staying well hydrated. Any questions about any of those risk factors and why that might be a cause of fluid volume deficit? No? Okay, cool. I'm just looking at my notes, making sure I didn't forget to tell you something. Okay, when we're looking at fluid volume deficit, some of the metabolic panels that we want to look at is our BUN and creatinine. Our BUN creatinine, if we're having a fluid volume deficit, would be elevated, right? So that would be something we would assess for. Our sodium, our potassium, and our chloride might also be elevated, okay? Because our fluid we're a little dry. So we're not excreting that from our body, okay? Our urine specific gravity, if I were to urinate in a cup and they were gonna do a urinalysis on me, my specific gravity and osmolarity would be up. My urine would be more concentrated. Someone with fluid volume deficit, their urine is usually dark, amber color. You can usually tell by the color of their urine how hydrated they are. So those are some things that I would pay attention to, is that when people are dry, their labs will be high, okay? It's a little mnemonic that helps, okay? When we're doing an assessment, we're looking for skin turgor, right? So the skin could be tented, meaning that it stays in a tented position for a period of time. And they also can have postural or orthostatic hypertension, hypotension, excuse me. So their blood pressure could drop with changing position. Okay, if we're not circulating well, if our circulatory volume is down, that's going to affect our blood pressure, and our blood pressure could drop. All right. What are we worried about if someone has orthostatic hypotension?
Safety.
Safety. Yeah.
Uses fall.
They can get dizzy and fall.
Yeah.
High risk for fall. Exactly right. Very, very good. All right, good. Any questions about that? All right. So let's talk a little bit about the populations at risk, okay? So we usually say the very young and the very old. And again, because their volume, because their body is small, is already lower than you and I. So their risk of dehydration, their risk of fluid loss is going to be much greater. Also, they can't communicate thirst, right? So if you have a small child that's crying and fussy, they can't necessarily tell us that they're thirsty, right? So we have to be able to intervene. We have to be able to assess and do that on our own. They have a higher percentage of body weight as water, and they have more extracellular fluid than intracellular fluid as baby. And they also have a higher fluid exchange because they have a very large body and lung surface area. So if you think of a baby, the biggest organ when they're little are their lungs. As we grow, we spread out. It's not as voluminous, but as a baby, they have very high surface area, and they also have a lower lung capacity. So they don't have as much reserve, okay? So things that can cause insensible loss and how we assess. So look at this picture here on the screen. We talked about fontanelles yesterday. We'll talk about them more when you guys get into live sim, but all babies have this anterior fontanelle at the top of their head. It is open till they're about 18 months of age. And when that anterior fontanelle is sunken or it's dipped in, that can be a sign of dehydration. So we want to be assessing the fontanelles. They might be very sleepy. Babies that are dehydrated tend to be very sleepy. Their eyes can look sunken. They might have no tears when they cry. Their cap refill will be reduced. Tachycardia, hypotension. Obviously, we know that that's a grave sign, and that's for any age. They can have dry mucous membranes, reduced skin turgor, low urine output, and they can have weight loss. Okay, so again, weighing children every day is very important, but these are some of the things we want to assess. So if you were assessing a newborn, we'd want to check fontanelles, checking eyes, checking skin turgor, capillary refill, look at net mucous membranes. All of those things would be important. Okay, questions? All right, and then the older adult. This is another high-risk population. They could have a blunted thirst, so they might not be able to sense that they need more fluids. They also have a decrease in lean body mass, which decreases their percent of body weight as water. So they have less volume per pound than we would. And at normal aging, their number of nephrons decrease and their renal function decreases. So they may not be excreting properly either. So they again could not have that sense of thirst. So again, here is our diagnostic testings. We know that the serum metabolic panel is very important. An elevated BUN and creatinine could mean dehydration and hypovolemia. CBC, we usually will see an elevated hematocrit. And again, that's because the blood is more concentrated. It doesn't have enough volume. So you have a little bit higher hematocrit. Your elevated serum osmolarity and specific gravity also would mean dehydration. So is it important for you guys to know this? Yes. Okay. Any questions? All right, and here's another awesome slide. You can see here's your urine. And the fact that they put this in like a smoothie blender bottle is really concerning to me. It bothers me because I drink from those all the time. I'm like, oh, gross. But this is, you can look at the color of the urine and how that determines how well hydrated you are. So if your urine is dark or a baby urinates in a diaper and it's got a little odor to it and it looks really dark, that would be a sign as well. If you're tenting skin, so if you pinch the skin and it goes down slowly, and then the furrowed tongue and dry mucous membranes are things that we want to assess as well. So I will let you guys look at this list. Might be a great question to see if you can identify dehydration. So I would star that. Okay. Any questions?
You have to remember the specific gravity number.
I don't want you to know the numbers per se. I want you to know that they would have an elevated specific.
Okay.
That wasn't gonna be my question either. So if we have to know BUN numbers,
You should know the normal BUN and creatinine. You should know your normal sodium and potassium and magnesium and all that.
Oh, okay.
Yeah. Or I'm not going to be too specific with the specific gravity. I just want you to know that will be elevated. Okay. All right. So nursing interventions, what do we need to do? I feel like you guys probably know a lot of this, but oral IV or IV fluid bolus would be our initial. We want to get them to drink, or we want to get their fluid volume increased. And we want to give isotonic solutions. There is a fluid solution cheat sheet that I posted on eLearning. I think is super helpful. But an isotonic solution is great because it really helps to like bulk up the cells. Okay. Avoid alcohol and caffeine during periods of dehydration or deficit. We want to do frequent vital signs and assessments, strict eyes and nose, daily weights, fall prevention, speech therapy if needed, check urinalysis, oxygen saturation, and orthostatic blood pressure. So we definitely, for someone that's dehydrated, we don't want them to get out of bed by themselves. We want to make sure we get orthostatics, at least a baseline for them, so we know that they're not at a higher risk for falling than they would have normally been. Okay. All right, here's another, just a little thing on IV solutions. Isotonic fluid stays where I put it. Okay. It has the same osmolarity as plasma. So the cells will stay the same. They won't be shifting from intra to extra. They're just going to bulk up. Okay. Normal saline, lactated ringers, D5W. Isotonic is iso perfect. Fluid stays where I put it. Okay. Just adds volume. Does that make sense? Okay. When we talk about hypertonic, fluid enters the vessels out of the cells. So it's going from intracellular to extracellular. It has a higher osmolarity than your plasma. Okay, so it pulls the cells back into the vessels. All right, D5 normal, D5 half NS are things that we would say. So the cells are going to shrink. Okay. Hypotonic, the fluid goes out of the vessels and into the cells. So the cells will swell. Okay, this has a lower osmolarity than plasma. Okay. We do worry about cerebral edema, especially in kids. So we need to be really careful with hypotonic solutions. So we don't want to give too much too fast, but half normal would be something that we would give for that. So definitely monitoring neurochecks when we're on a hypotonic solution. First of all, I want to just make sure I mention that the doctor will always order the fluids. It is not your job to decide as a nurse what fluid your patient's going to get. Therefore, it would not be something I would test you on. But I would want to know, I do want you to know why we're giving the fluids, right? So if someone is dehydrated, I know that normal saline is a great fluid cell bulker, right? It's going to help to fill up those cells and add volume. I also know that if I've had surgery, that LR is also a great cell bulking, that if I've lost blood, lactated ringers is a great option to increase volume, okay? And so the other ones we'll talk more in depth later, okay? But isotonic was the best one to treat fluid volume deficit. Okay. All right, let's talk about, are we good?
Yes.
Okay. Fluid volume excess. Okay. Fluid volume excess is when both water and sodium are retained by the body. Remember, salt and water love each other. They are besties. They love to hang out together. When one is low, the others, you know, they correlate very, very well. When both water and sodium are retained by the body, it can cause fluid overload. Okay. So intravascular and excess interstitial edema. So you get hypervolemia and swelling. It's interstitial edema. Things we see, heart failure. That's probably the number one thing we're going to see this semester. Cirrhosis of the liver. We see a lot of it. We see ascites in the belly, all sorts of fluid volume shifts. Renal failure. Well, obviously, if your kidneys are not filtering and getting rid of fluid or getting rid of that waste, we're going to have an excess in our body, right? Adrenal gland disorders, overuse of steroids. We need to be careful when giving long-term steroids. Stress conditions, excessive intake of sodium-containing foods, okay? Drugs that cause sodium retention. So some of our cardiac meds and such might cause that, or extra sodium-containing IV fluids. Okay, so we could overhydrate someone, okay? We don't want to do that either. So when we think about the heart is not pumping, working well. So you have poor perfusion, causing fluid volume excess, or the kidneys are not eliminating fluid. Therefore, you have an excess of fluid volume as well as an excess of sodium and potassium. Okay. With cirrhosis in the liver, there's increased pressure and the fluid has nowhere to go. So that's when we see the third spacing. So we see ascites in the belly and the weepy skin where the fluid's kind of leaking out of the skin. Okay. So we want to try to move fluid back into the intravascular system. So being really careful with how much fluid we're giving, not to fluid volume excess them involuntarily by circulatory overload. So remember that salt holds on to fluids. So the more hypernatremic you are, you're also putting yourself at risk for fluid volume excess, because sodium's going to hold on to that fluid and prevent it from being excreted. Okay. That's why we look puffy. Right. So when you eat Chinese food and the next day you're like, oh my God, I look so puffy and I gained 4 pounds. Well, it's because your body had so much salt. It's holding on to all this extra fluid. Right. Does that make sense? I mean, 4 pounds minimum with Chinese food. It's so good, but you suffer for it. So just, you know, think about those things. Our diet impacts our fluid shifts. All right. Where's my cursor? There you are. All right. So things that we're looking at as far as labs for fluid volume excess. Obviously, if we have too much volume, we're going to have a decreased BUN and creatinine. And our electrolytes are going to be decreased as well. Okay. CBC, our hematocrit will be lower because we're diluting everything. Everything's diluted. We got too much. Okay. Our serum osmolarity will be decreased, and we might see pulmonary congestion on an X-ray because, again, our lungs also hold on to fluid. Okay. Does that make sense? So when you get too much fluid, your labs are low. When we have too little fluid, our labs are high. Okay. All right. Fluid volume clinical manifestations. So we see confusion, especially in the elderly. When they are fluid overload, they're like get all confused and wonky. They can be weak. We see distended neck veins. You can see right here. This is a perfect, beautiful distended neck vein. We could put a nice line in that. That's beautiful. Interstitial edema right here. Anasarca is this 3+ pitting edema. Right? No bueno, not good at all. Tachypnea, dyspnea, crackles in the lung, shortness of breath. So we know that, especially with that left-sided heart failure, we get a lot of pulmonary edema, a lot of interstitial lung sounds. Hypertension, bounding pulse, and polyuria. So we might be urinating a lot, trying to get rid of it. okay? So nursing interventions for fluid volume excess, we want to restrict fluids, okay? Sodium restricted diet, monitoring for edema, listening to lung sounds. That's what LS is, lung sounds. Daily weight. So if we increase by 1 kilogram, that's too much. So 2.2 pounds. Elevate legs to decrease dependent edema. Administer diuretics as ordered. So we might use a loop diuretic like Lasix. Elevate the head of the bed. Teach fluid management at home. So people that have cardiac issues might need to manage their fluid volume intake at home. Supplemental oxygen as needed, reduce IV flow rate. So even though we may to give them a little fluid to help with the shifts, we don't want to overhydrate, okay? We don't want to make it worse. And then repositioning them is really important, especially if they have pitting edema. The risk for ulcers and such, skin breakdown is very, very high for these patients. So we really want to make sure we're doing really good skin checks and rotating them as frequently as possible. Okay. All right. Just looking at my notes. Make sure I don't forget anything. All right. So IV therapy. So this is new to you guys. Yes? You didn't do anything on IVs last semester. Okay, cool. All right. So we give IV therapy to, one, either hydrate someone, two, to provide electrolytes that are maybe imbalanced, and or administer medications or blood, right? So IVs are a staple in nursing. It's imperative that we know how to put them in, we know how to use them, we know how to assess them. So we are going to have a part of this lecture about assessing IVs and what is an IV and what are we looking for and all of those things. So all of those things are very important. There's constant evidence-based testing and stuff going on about IVs and how frequently we should change them. And we used to change them every 72 hours, no matter what. And now we're actually not. We're actually leaving them in as long as they are functioning and not looking angry. Because again, veins sometimes are very difficult to access. And so we don't want to remove good access if we can't get another access. So we're giving IV fluids and we have an IV in the arm. We have to worry about certain things that might cause problems. So if we're not assessing our IVs, these are some of the things that can happen. Infiltration. So it's this bottom left, and that's basically that the IV blue. Infiltration means that the arm will look swollen, it will be cool to the touch. Our goal is to stop the infusion immediately because again, that whatever's going through the vein is leaking into the tissue. And apply warm compress and elevate that body part that is has the infiltration. That's probably the most common thing that you see. It's not always something that you can prevent, but it's definitely something that could be really bad if you don't find it, right? So veins are weak and sometimes they break. And when they break, the fluid that you're infusing will leach into the tissue. If you're not assessing your IV and that goes on for a long period of time, we're going to see some of the things that could come from that. Next one is an infection. So if you're, you can get, an infection in the IV. So let's say the catheter's been in there too long, or someone didn't clean the hub well, and we got some sort of bacteria into the vein that can cause a cellulitis or an infection in the tissue surrounding. So we definitely would want to remove the IV. In that situation, we'd probably apply some ice until that kind of calms down. Phlebitis. Phlebitis is an inflammation of the vein. So phlebotomy is vein, phleb is vein, itis is inflammation. So anytime you see a word that ends in itis, that means inflammation, and phleb is vein. So phlebotomy is accessing veins, okay? So phlebitis is an inflammation of the vein. So very often, if you'll see a streaking, so a nice red line that streaks up the arm because the vein itself is inflamed. So if you see like a red line, like almost like a track line up a vein with an IV, then that's a phlebitis and that needs to be removed. And we need to actually probably go to a different arm because sometimes it's really hard to determine the exact pathway of the vein and you don't want to access the same vein in a different spot. So we typically will go to another limb or another area, okay? Sometimes we see phlebitis with meds that can be caustic. So we do have some antibiotics like Flagyl, for example. It's a macrolide and it can be very caustic to veins. So, you know, when we're infusing it, we need to really watch the IV site much more closely to watch for things like phlebitis. Usually the patient will complain that it hurts to infuse and then you might see some streaking. So the next one is extravasation, and we actually do see this more commonly in pediatric patients. This is an infiltration, but an infiltration by a vesicant. So if we're getting a medication, like let's say vancomycin. So vancomycin is a very strong antibiotic. And if you have an infiltration, and remember an infiltration is when the fluid leaks into the tissue, right? If that happens with a vesicant, such as vancomycin, it can cause tissue necrosis, which is what we see here with this little baby's foot, okay? This is bad. This can cause significant damage to the tissue, to the limb. Chemo is another reason why everyone gets portacaths placed when they're going through chemotherapy. Because if you get an infiltration with a vesicant like chemotherapy, it can cause this really bad necrosis. You actually will call the doctor when this happens. You want to keep the IV in place and you actually want to withdraw as much fluid as you can from that IV line to try to get as much of the vesicant out. Then you would remove the IV, okay? I've seen kids that need like grafts and stuff from something like this. So it is a very serious thing. So making sure you're monitoring super closely. Next is thrombophlebitis, which I don't have a picture of, but it's basically a clot in the line. So if you have an IV line, so I'm sure any of you work in the hospital know that if you get an IV put here, every time your patient bends their arm, it's going to beep and drive you insane. I don't know if you've had the pleasure of that experience. It's horrendous. It's annoying, especially in the middle of the night. Every 5 seconds, the IV is beeping because the patient turns over and bends their arm. Makes me crazy. As an IV nurse, I literally would remove them from the AC and put them somewhere else in the body because it would make me crazy. But you also can see that when there's a clot in the line. So sometimes if you've been HEP locked, so you have an IV and it has not been accessed for a period of time. So even if we're not using an IV line, it's important that we flush it every shift, right? To make sure it's patent. Because what happens is if we need to use it in an emergency and nobody's accessed it, nobody's flushed it, well, now we have this clot in the line and it's not going to work. So if you're unable to flush it, you don't want to force it because you don't want to push that clot into the vein. You want to just remove the IV and get a new one. Okay. But that's why it's important to flush your IVs every shift, even if you're not using them. Even if Joe Schmo is going to be going home and discharge papers are there. God, guys, I've seen it. They're ready for discharge. Everything's signed. You just haven't done the discharge interview yet. And then all of a sudden that something happens and they desat or they're unconscious and you're like, holy crap, calling a rapid response. And thank God you checked your IV. So never remove an IV either until the patient is literally walking out the door. That's just practice. Something I'll tell you ahead of time. So that's a thrombophlebitis. And then lastly, we have a hematoma, which I also don't have a big picture of, but we all know what a bruise looks like. That's what a hematoma is. It's basically a bruise. It's still okay to use. So a lot of our patients, especially our elderly patients, are on blood thinners, they're on medications or they're anemic and it causes them to bruise. So just the process of inserting an IV can actually cause them to bruise. So as long as it's patent, it has a blood return, it's flushing well, even if it's bruised, it doesn't mean we can't use it, but it does mean we should watch it pretty closely just to make sure that there's no infiltration or anything that happens. Questions about IV. So there, I also have an additional IV PowerPoint that's on e-learning. I'm not going to go over it in class, but it's just basically this, but in more detail. So feel free to download that and take a look at that as well. Okay.
Professor,
Sure.
I'm sorry, can you repeat how often we have to assess the IV site?
Every shift, I say every 4 hours, definitely every time you give a medication. So if I'm giving a 9 o'clock IV antibiotic, a 12 o'clock IV antibiotic, and a 4 o'clock antibiotic, I'm going to assess that IV before giving every antibiotic. However, if I have a patient that's not getting anything through the IV, I'm going to assess it at the start of my shift, and I'm probably going to assess it towards the end of my shift, just to make sure it's patent. I wouldn't want to leave the IV not assessed prior to the next shift coming on, because if change of shift happens and we didn't check it and then we don't have a working IV, then that's not good. So it's dependent on the situation. Good question.
And where in the book can we find like those informations in more details?
I don't know exactly where it is in the book. It's in my PowerPoint though as well. I don't know. I'd have to look at the book to see. If you can send us a little note, an email, and let us know or post it somewhere. Okay.
All right, thank you.
Professor,
Yes.
about extra version, you said we keep the IV in place and also suck out that fluid that is in.
So what we would do is we would stop the infusion and call the doctor. Okay. Most of the time you're going to stop the infusion and remove the IV. This is the one case that you don't remove the IV until the doctor tells you to. He might be the one that comes up and tries to remove the vesicant. He might ask you to do it, but you would just take an empty syringe and pull back on the catheter and see and take out whatever you can.
Okay, thank you.
You're welcome. Any other questions?
I just had a question from the skills book.
Yeah.
It talked about IV removal, and if a piece of the plastic gets stuck in the vein, you apply a tourniquet, but it didn't explain like what happens to the plastic.
They would need to go in and remove it manually under ultrasound.
Okay.
I've never seen it happen. It's scary because again, if that gets into the heart, that's a problem. So you apply the tourniquet basically to prevent it from traveling. And they would need to go in by ultrasound and manually remove it. Yeah. Scary. Any other questions?
Professor, extravasation is only for kids? But
I can't hear you. Say that again.
extravasation is only for kids, or adults can have it too?
Yeah, anybody. It's more common in kids because their veins are fragile.
Okay.
And their tissues absorb much quicker. They have less tissue than we do. So it happens really fast in kids. If it happens in an adult, you didn't look at that for a long time.
Okay, thank you.
Usually adult tumor is going to tell you that something's wrong, something doesn't feel right, or a kid isn't going to tell you. And that's why it's more common in children. Okay, good question.
Could you tell me a little bit why corticosteroid and stress condition will causing the fluid overload?
What causes fluid overload?
Corticosteroid and stress condition.
Corticosteroids, it's not someone that just takes them for like a 10 or 14 day course, but corticosteroids can actually keep fluid where they are and prevent the fluid shifts. So if you're on steroids for a long period of time, it can cause problems, which is why we want to monitor them much closely. And what was the other one?
Stress condition.
I'm sorry, I'm having a hard time understanding what you said.
Stress.
Oh, stress conditions. Sorry, Mike. Stress, well, when we're under stress, our body circulation is affected. We can become baseline tachycardic and tachypnic, and it just helps, it can inhibit the proper fluid shifts in the body. Yeah, it's just kind of one of those weird phenomenons that extenuating stress can cause.
Okay, thank you.
You're welcome. So again, I think we pretty much talked about most of this. If we have a central line, we want to avoid bloodstream infections. So we really make sure that it's a sterile process, that we are using good hand hygiene, aseptic technique. This is, if you get a bloodstream infection, which is called a clepsy off of a central line, that is basically the nurse's fault. And the hospital will come at you. So be really careful with your cleanliness, especially of central line, making sure you're cleaning the hub, that you're using a good sterile aseptic technique. Fluid volume overload, again, that's just monitoring your patient when they're getting IV fluids, preventing that from happening. And air embolism. So this would be honestly, guys, you would have to give someone an entire IV line full of fluid to get an air embolism. It's not that little itty bitty air bubble that you see. That might be problematic for a small baby, but for an adult, a little bit of air is not going to be traumatic, but an air embolism would be too much air inside the vascular system that is considerably blocking blood supply. I've never seen it in my life, thank God, but you would see patients to be very anxious, short of breath, complaining of chest pain. And this would be, you want to immediately clamp the IV and call, basically put them Trendelenburg, get all that blood flow to the heart and lungs and brain, and call for a rapid response. So, okay.
Question.
Yeah.
So for the IV insertion, you have to use aseptic technique or sterile? Like, do you have to have a sterile bag?
For a regular IV, it's aseptic. For a central line, it's sterile.
What is the difference?
Peripheral IV is just aseptic, clean. If you have a central line, so a PICC line, a portacath, something that stays in for a long period of time, that has to be a sterile
Oh.
technique.
Okay, thank you.
You'll learn more about those next semester, I think. So think like a nurse, you're caring for, so here's the one thing I wanted to mention. Please, please, please do not talk over each other. If you want to respond or ask, I'm just going to ask you to unmute and be patient if someone else is talking, and I will try to call in everybody, okay? So you're caring for a patient receiving an IV antibiotic. While the infusion is being administered, you enter the patient's room and find this. First of all, I don't like that dressing at all, but what's our next action? What do we think?
You stop the
Remove it.
Stop the infusion, okay.
Remove the IV.
Say that again, Marie.
Removing the IV.
Removing the IV. What do we think's happening?
It's infiltration.
You think it's infiltrated? Okay.
I think it's a hematoma.
Think it's a hematoma? Okay.
Like infection.
Think it might be an infection. Hard to tell, right? Let me pull up the chat box.
Yeah, it's hard to tell. You don't know if it's swollen. It's red.
Yep, definitely looks bruised because see how it's like yellow around here?
Yes.
So I would say we would stop the IV. We would flush it. We would make sure it doesn't look puffy, swollen. I think it's probably a hematoma, just a bruise. I would ask the patient if it hurts. I don't see any streaking. So if I saw a line of redness going up here, that would tell me it was a phlebitis. If it looked extraordinarily swollen, I would think infiltration, but it doesn't look swollen or any streaking. So I think that's a bruise. So I would stop the infusion. I would flush it, make sure it's not painful, make sure that it's infusing well. And if it is, I would probably continue with the infusion. Okay.
Professor, I have a question.
Yeah.
Okay.
We're gonna have the like those picture in the exam and then to say if it's infiltration or
No
hematoma?
pictures. No.
Oh, okay.
About that. I just wanted you to see it. Just to,
To detect if what is it in the picture. So I was.
I have a hard time hearing you, Marie. Say that again.
I said it's gonna be really hard to detect what is it.
No, I won't do that to you yet. You haven't had enough practice.
Thank
Don't
you.
worry. Okay. All right. I'm going to skip over math for now. We're going to do math at the end, okay? All right. So that's fluid balance. Questions about fluid balance?
I just a little bit wondering the aseptic technique. What is the different aseptic and sterile technique? They should be same for me.
No, aseptic would be using gloves, a mask, cleaning the site. Immaculate, I'll be right with you. Thank you for raising your hand. A sterile technique would be sterile gloves, sterile field, everything sterile.
Okay, so aseptic is like clean technique.
Clean, correct.
Okay.
Yep, good question. Good, all right. Are we ready for electrolytes? Let's do it. All right. So let me just go to my slideshow here. So I understand that there were 2 electrolyte PowerPoints. The one that was number 2 was the one that I had added stuff with PD and stuff. So that's the one we're going to use today. I didn't realize that they were both open. I meant to hide one and just use the second one. So you have 2, they both say the same thing, but one has more. So use the one with more. All right, let's get started. Let me share my screen. All right, you guys can see my screen. Immaculate, what's your question?
I was asking about anasarca.
Okay. Anasarca is when you have such bad edema that your tissue is weeping. So when you push on the skin, fluid actually seeps out of your pores. So it's called third spacing.
Okay, thank you.
You're welcome. All right, so that's a great thing. I like how she raised her hand. When she raised her hand, I was able to see a hand on the screen. So I knew that Immaculate wanted to say something. So let's try that today. Let's see how that works, okay? Just so that everybody can be heard without talking over each other. I'm figuring out the Zoom stuff, guys. And as soon as I figure it out, we'll be back in class. So it's whatever, it is what it is. We'll do our best. All right, so let's talk about electrolytes. So this should be new content for you. All right, and we're going to talk about all the different electrolytes today, as well as, there it is, as well as some of the problems that go along with these electrolyte imbalances. So fluid and electrolyte balance is the process of regulating extracellular fluid volume, osmolarity, and plasma concentrations of electrolytes. So we need all these different electrolytes to help with our cardiac function, our renal function, our metabolism, all of those things. So making sure that they're at a healthy level is important. When they're at an unhealthy level, too high or too low, it causes problems in our body. And we need to be able to identify what those problems are and how we are going to help counteract that and help the patient be better, okay? So electrolytes are substances that are charged particles or ions when placed in water, okay? Cations are positive, anions are negative. Yes, back to chemistry. I'm sure you're all excited about that. So much fun. So intake and absorption, okay? There's 3 processes of electrolyte and fluid balance: intake and absorption. So we take and drink fluids and eat food in our body. They get absorbed, and the electrolytes are absorbed by the body and are moved through the body by absorption. So different parts of the body use different electrolytes for different reasons. So it's our job to ingest them, and then it's our body's job to figure out, where do I need them? Okay, so they infuse them, we take them in, and then they get absorbed. Once they're absorbed, they get distributed, and this is the process of moving the fluids between the different body compartments: intracellular, extracellular, and then the interstitial spaces, okay? Output is when, after we've given the body everything that it needs, that will say, well, I don't need these, I'm good. And the rest of those go out through the kidneys as waste. Okay, that is your output. So your intake and output is the process of absorption and distribution. Okay, does this make sense? One has to happen before the other can happen. Okay. All right, so optimal extracellular volume, deficit and excess we just did. Osmolarity is the concentration of the blood, too dilute or too concentrated, okay? And then we want to maintain optimal electrolyte concentration. If it's too low, it's hyperemia. Emia, the word E-M-I-A, means blood. So when you're looking at medical terminology, anytime you see the word E-M-I-A, that means blood. So hypo is low, emia is blood. So if I want to talk about sodium, I put Na, which is the ion for sodium, in the middle, and I have hyponatremia. Got it? So that's how when you're looking at these words, if you're not sure what they mean, think about the root words, because they're all, you're going to see as you go through the program, they're all going to be the same. Emia always means blood. Anemia means no, none. A is none or low, right? So anemia is low blood. So emia always means blood. Okay. All right, so causes of fluid electrolyte imbalance, very similar to what we just talked about when we talked about excess and deficit. Intake and absorption, normal output, if it's any deficiency in intake or absorption. So if we're starving ourselves because we're trying to lose weight, that's a change in our intake, okay? Increased output, that's not balanced by intake. So if you are nausea and vomiting, right? We're not eating because we're sick and we're outputting way too much, okay? So that would affect our intake and absorption, all right? Output. Output is less than excessive or too rapid of intake. So we either have kidneys that are not working well, so we're not excreting enough urine, or we're like overhydrating with fluid for some reason or another, okay? Decreased output, that's not balanced by decreased intake. So basically we're drinking a lot, but we're not putting it out. And then there's alterations in distribution. So this is when you have fluid shift problems. So this is when we talked about liver issues or pump issues, where we see third spacing, okay? When we have this happen, the electrolytes will shift as well. And this can be problematic, okay? Again, this is the same slide as before. We also have populations at risk when it comes to intracellular and extracellular deficiencies. Things that we see that cause an increase in dehydration in children. Vomiting and diarrhea are probably number one. Decreased oral intake. So if you have a kid with a respiratory issue that's all stuffed up or coughing a lot and can't drink, then we're going to have a decrease in oral intake. Again, nasodiastric suctioning, hemorrhage, burns, excessive hot weather. Babies that are sweaty, they don't always sweat like you and I do, but they do have a lot of heat and extra insensible losses. So we want to make sure we hydrate them well. And then obviously if you have a juvenile diabetic, we worry about diabetic ketoacidosis, which we'll talk about in a couple weeks. So pediatric signs of dehydration. Don't memorize this slide, but I do want you to be able to understand what the signs and symptoms in a children look like, because they are often different than what you might see in an adult, okay? With mild dehydration, we're just going to go down this slide first. If they lose up to 5% of their body weight, level of consciousness, alert, restless, okay? They're usually restless and fussy because they're thirsty. Their blood pressure stays normal, their pulse is normal, skin turgor is normal, their mucous membranes will be moist, their urine may appear normal, fontanelle is normal. So again, everything looks pretty normal, but they're just alert and restless, okay? Maybe they've had a little bit of weight loss. As we go into moderate, so 6 to 9%, they become more irritable and they become lethargic at this point. Babies that are dehydrated get very, very sleepy, okay? Older children get more restless. So infants and toddlers would become more sleepy, where an older child might become really restless. Their blood pressure may be normal or on the low end of normal, or it might be normal when they're laying down, but as soon as they change position, they get postural, okay? Postural hypotension. Their pulse may be normal or a little rapid. Their skin turgor becomes poor. Their mucous membranes become dry. Their urine output will get a little dark. Their thirst is moderately increased. Their fontanelle will become sunken. So when they're just moderately dehydration, we are going to see very significant physiological changes in our patient. We should never see severe in a child, because again, it's so obvious when they're just moderately dehydrated that we really should not see a child get to be severe, okay? They become almost comatose. Their blood pressure is extraordinarily low. They're extremely tachycardic, very poor skin turgor. Urine is decreased or absent. So again, just very, very grave signs in a child, okay? So I would say if I had to look at this chart, if I were going to ask you questions on dehydration, I would want you to make sure that you know what would some of the signs and symptoms be, and that this would be the area of concern. When we're here, this would be grave. Like if we get here, then you didn't do your job. So I really want to see that you are able to identify dehydration, okay? So knowing the signs and symptoms, what might you see? Good, everyone understand? Okay. All right. We talked about older adults as well. I got to combine both of these PowerPoints. I'm keep trying to improve the wheel, and then I give you the same thing over and over again. We already talked about this as well. All right, so let's get into the different electrolytes and what these imbalances might look like, okay? So the electrolytes we're going to talk about today are sodium, potassium, calcium, magnesium, and phosphorus, okay? We're going to do an in-class activity, but I'm going to go through the electrolytes first, and then we're going to take a quick break, and then we're going to do an in-class activity, okay? All right. So, sodium, we're going to start here. All right. Sodium is the most abundant electrolyte in the extracellular fluid. You guys need to know your normals, 135 to 145. It's found in many foods, including bacon, processed canned foods, as well as table salts. We suggest 1,500 to 23 milligrams a day. It's important to know where sodium is found in everyday foods, because if you have a patient on fluid restriction, we should avoid some of these foods, right? We know that a lot of processed foods have extra sodium. That is a preservative that keeps them fresher longer. Those are things we should avoid for patients with sodium restriction. Okay. I keep losing my cursor. There you are. Okay. So the sodium imbalances that we see, hyper and hyponatremia. Okay, so that's low sodium or high sodium. Etiologies include impaired thirst mechanism, profuse sweating. So this is high sodium levels. Diabetes insipidus, Cushing's syndrome, inadequate oral electrolyte use, okay? Hyperosmolarity of extracellular fluid, meaning we've overhydrated here. Cellular dehydration, so the intracellular fluid is low, the extracellular fluid is high. We have excessive thirst, dry, sticky membranes, and we might appear restless, okay? During treatment, we want to monitor for headache, nausea, vomiting, increased blood pressure, and confusion, okay? Usually critical would be greater than 160. This would be really problematic. We'd probably need this patient to be in a more acute care setting. Hyponatremia is serum levels less than 135 and critical would be less than 115. Diuretic use, okay, so Lasix was an example of that. Renal disease, adrenal insufficiency, vomiting, diarrhea, excessive GI losses with an NG tube, irrigating of an NG tube with water instead of saline, because we know saline has sodium, water does not. Burns, again, burns are significant fluid loss, and then heart disease. So we see edema, muscle cramps, weakness, fatigue, anorexia, nausea, vomiting, abdominal cramps. As we get more and more critical, our levels drop lower and lower. Headache, depression, lethargy, hyperreflexes, muscle cramps, twitching, and tremors are common. So we want to administer sodium-containing fluids, right? So normal saline. Normal saline is 0.9% sodium, right? So we'd probably want to give full sodium fluids. And also intake of sodium-rich foods. Again, monitoring for safety is very, very important. When we talk about potassium, is a major cation in intracellular fluid, okay? There's only a little bit of potassium in the extracellular fluid. It's primarily intracellular. The levels are 3.5 to 5.3. You must know those levels. It's vital for skeletal, cardiac, and smooth muscle function. So the heart is your largest smooth muscle organ in your body, and potassium being too high or too low directly affects your cardiac function. So potassium is a really, really important electrolyte to monitor, okay? We must take in potassium every day. So eating foods rich in potassium is important. Green leafies, friends, green leafies. Fruits, vegetables, meat, and fish. Imbalances could lead to cardiac arrhythmias. So when we're looking at hyper, high potassium, and hypo, low potassium, here are some of the things that we're looking at. Serum levels greater than 5.3. Critical would be greater than 7. Renal failure. Potassium sparing diuretic use. Excessive potassium intake. Adrenal insufficiency. Acidosis, which we'll learn about in a couple weeks. Severe tissue trauma, starvation, and certain medications can cause high potassium levels. The antidote for high potassium might be calcium gluconate, sometimes insulin with glucose, sodium polycistrine sulfonate, which is known as K-exolate. I'm sure if you work in the hospital, you've heard of K-exolate. That is sodium polycistrine sulfonate. Diuretics can help pull out potassium, and severe levels of dialysis. So if we haven't had dialysis, our potassium levels could get really high. Okay. When we talk about hypokalemia, less than 3.5, critical less than 2.5, potassium depleted diuretic use such as Lasix, corticosteroids, some antibiotics, severe vomiting, gastric suctioning, alkalosis, long-term potassium, or poor IV fluid therapy. We would see flat or inverted T waves. So when we're on a telemetry monitor, we want to see the nice monitor strip. Well, we would see that the levels would be inverted. It's not something you need to know now, but it is important to know that we would see a dysrhythmia. You don't need to know what the dysrhythmia is, but just knowing that a dysrhythmia is a cause of hypokalemia. Decreased bowel sounds, muscle cramps, and if we're on digoxin, increased toxicity from that. So we would want to give potassium replacements. So we either give potassium in a pill form, or we can give IV potassium depending on how low and how critical it is to get those levels up quickly. Okay. Calcium. So all of these are going to come together when we do our little activity in a minute. Yes, Mike, you have a question?
Why the hypocalcemia causing the digoxin toxicity?
So digoxin and potassium work very well together. So if you have high digoxin often can maintain, hold on to potassium levels. So if you have high potassium and you're taking digoxin, it can cause a problem. So we need to make sure that we are monitoring potassium levels very closely with digoxin. We will learn a lot about digoxin, Mike, when we talk about perfusion later in the semester. We have a whole PowerPoint, couple slides on it. So we'll go through that in depth later, but great question.
Thank you.
You're welcome. Okay, calcium. Someone asked me earlier about calcium and albumin. I'm not exactly sure who it was. Magina, was that you? Yeah. So this is a very confusing phenomenon. And I talked to a couple other faculty about it because I'm like, how do I explain it to students in a way that helps it make sense? The details of it is not something I'll necessarily test you on, but I want to make sure that you understand. Calcium actually binds to albumin. So when you have calcium in your blood, it basically lives and coexists with the blood protein. So when you have problems with low albumin, it could also result in low calcium. Okay, because if there's not enough albumin in the body, the calcium doesn't have anything to bind with. So I don't know if that helps to explain it a little bit better. They're basically like partners in crime, calcium and albumin. So when you're checking calcium levels, if they're off, we want to check albumin levels because chances are good that if one is off, it might be a result of the other. Did that help explain it a little bit better for you? Yes.
Yes, thank you. But I'm having some issue understanding how starvation can cause hyperkalemia.
So if you are not eating properly and you're dehydrated, you're not having good fluid volume, your body is going to hold on to everything that it can. It's not going to be excreting it properly. It's not going to be distributing it properly. And therefore the electrolyte imbalances can be very significant. So they can be either very, very high, depending on the circumstances, or very, very low. So depending on what the starvation is, for patients with anorexia, they typically overhydrate and we tend to see the labs go up because we're so diluted that we don't have anywhere for the electrolytes to go. Does that make sense?
Yes.
Okay, cool. All right. So for calcium, several major functions of the body: neuromuscular transmission, muscle contraction, blood clotting, bone and teeth formation. So calcium really has to do with our body's, bone structure. And we know this. We know that we get osteoporosis as we get older due to lack of calcium and calcium degenerating as we get older. Normal calcium levels are 9 to 11. And levels controlled by vitamin D, calcitonin, and our parathyroid hormone. Most of the time, if we have issues with our parathyroid, we definitely will see issues with our calcium levels as well. They typically go hand in hand. Okay. So we're looking at calcium imbalances. We're looking at hyper, greater than 11. So again, hyperparathyroid, bone malignancies, or drug toxicities are things that we might see. Hypercalcemia. Things that we see are fatigue, weakness, decreased reflexes, headache, impaired cognition, nausea, vomiting, etc. Treatment is we really need to fix the parathyroid. So we need to be with an endocrinologist, and they might need to do some sort of surgery to sort of fix the function of the parathyroid. If it's a medication or a drug that's causing it, we would need to stop. We would discontinue that drug. Okay. When it comes, we don't see hypercalcemia all that often, to be honest. It's more about the thyroid issue. It's more of an endocrine disorder. When we see hypocalcemia, it could be after blood transfusion. Again, an issue with the parathyroid where the hormones are decreased. An elevated phosphorus. Phosphorus and calcium also are best friends. They like to travel together as well. So if we have elevated levels of phosphorus, we're probably going to see a lower calcium, okay, as well as magnesium, low albumin, alkalosis, etc. So if we see hypocalcemia, you can see bradycardia, low blood pressure, muscle cramps. Our reflexes will be hyperactive. Confusion, seizures are also things that we see. And we'll talk about the Chvostek and Trousseau signs in a minute. All right, magnesium. Magnesium is essential element in all living cells, 1.5 to 2.5. Our bones contain 60% of the body's magnesium. Our muscles contain 40%. It's needed for energy production, protein synthesis, and neuromuscular function. Hyper and hypomagnesium. Serum levels greater than 2.5. Bowel disorders, overconsumption of antacids. Antacids, so Tums, people with like heartburn and reflux, we tend to see hypermagnesium because that is basically magnesium citrate. If they're taking too many Tums during the day, it can cause that. Renal failure is another sign, especially in older adults. Our muscles can seem flaccid. We could have decreased deep tendon reflexes. So we want to discontinue medication. We want to give calcium gluconate. That is also the antidote for magnesium sulfate. That I would star. And then if we have severe levels, we might need to do dialysis. Hypomagnesium, less than 1.5. So malabsorption, poor dietary intake, and or medications can cause it. So muscle cramps, tremors, etc. Increases with dietary intake. We need to give magnesium salts to help replace it, okay? And then phosphorus is the second most abundant mineral in the body. It works with calcium. Again, they're best friends. They like to maintain bone and tooth integrity. The only thing we really see, we very, very rarely see hyperphosphatemia. It's usually hypo, and it's usually found in patients that are abuse alcohol, take excessive antacids, are very, very low vitamin D. And there's a few medications that might cause phosphorus issues, but typically not very that are common. All right, so we're gonna stop here. I'm gonna close this for a second. Marie, you raising your hand?
Yes. I would like to know if we can use calcium gluconate for hypocalcemia too.
We're gonna do more because we're gonna do an activity that's gonna go over it all in much more depth,
Okay.
right? I want everyone to take just a couple, 10 minutes. I need to use the bathroom. I need to grab some water. I'm starting to get very dry. And so I also want you to pull up, and I will share it so you guys can grab it while you are on your break. I want you to, pull up this sheet. I'm just going to find it. All right. So it looks like this. Okay, so this is the sheet that I want you to get. On the break, we're going to come back at like 10:48. Just go to the bathroom, take a quick break, get some water, and we're going to break into breakout rooms. So if you don't have this accessible, either print it, pull it up on your computer, but you will not be able to see it in the breakout rooms because Zoom doesn't allow it, which is annoying. But that's what we're going to do. So if you could get that or get a copy of that, have that accessible, that would be great. And then we will come back. All right, we are recording. So, so remember, when you're on a pump, you're always rounding to the nearest whole number. So that would be something you would watch for, okay? Now we're going to build upon that when we're calculating the hourly rate. So sometimes, I'm going to actually go to my whiteboard for a second. Let me find out how to do that. All right, let's go to my whiteboard. So when we are doing, if we have 1,000 mLs, you guys can see my whiteboard, right? Yes, okay.
Yes.
We have 1,000 mLs, and we want that to be administered over 8 hours. Again, that's going to be 1,000 divided by 8, right? So we're just going to take 1,000, divide that by 8. I get my calculator.
$1.25.
5 an hour. Okay, so you guys all know how to do this, yes? Okay.
Yes.
So what we're going to elaborate today is, have you done drop factor? Yes?
Yes.
We'll review that
Yes.
as well.
Yes.
Okay. So if you are doing drop factor, and if we have a say, we want to give 400 mLs over 2 hours, and the drop factor is 12 drops per minute. How many drops per minute will you give? All right, so it's another level of question. Okay. So we would take, I will warn you, it is hard to do math online, but that's okay. We could always do it in sim as well if you need practice. So we would take the 400 and we need to multiply that by the drop factor, which is 12. And then we have to divide it by time in minutes. So this is the difference. We have to divide by time in minutes, not hours. So if I have 2 hours, how many minutes is 2 hours?
120.
120.
120. Great. So I would divide this by 120. All right, so I take my calculator. I'm going to do 400 times 12 divided by 120, and I'm going to get 40 drops
40.
per minute. Good? Does everyone know how to do this? Is anyone confused about this? Want me to do another one? Because again, if this is something you did last semester, I don't want to spend a ton of time on it. Let me see, I have a couple chats, hold on. Oh, good, okay. All right, so that would be drop factor. So remember, when it's on a pump, it's the volume over time in hours. And when you're doing drop factor, it's the volume times the drop factor over time in minutes. So when I see students have an error, it's usually forgetting to convert it to minutes. Okay, good? All right. If you don't tell me, I don't know. All right, so let's go back here really quick. And I just want to look at this. All right, I'm actually going to go back to this PowerPoint. And we're going to talk about weight-based formula. So we know that 1 kilogram is equal to 2.2, I'm sorry, 1 pound is equal to 2. Why am I having a brain fart? 1 pound is equal to 2.2 kilos, or vice versa. Yes. This is correct. Oh my God, I've been talking too long. My brain is smoke's coming out of my ears. 1 kilogram is equal to 2.2 pounds. So if I am a 120 pound human, I would divide that by 2.2, and I would be 54 kilograms. Yes? 54.5 kilograms. So everyone knows how to convert kilograms, yes? Anybody not? Okay. So if I have a formula and I'm trying to find out med math, if I have a doctor that wrote me an order and it said, give Tylenol, and I want you to give 15 milligrams per kilogram per dose every 4 hours. That would be my order. So if I am 120 pounds, right? 54.5 kilos. I want to take my kilograms and I want to insert it into my formula. Okay. So now my math is going to be my 15 milligrams divided by 54.5 kilograms. Okay. Or it's times. So if I have 15 times 54.5, that means I can have 817.5 milligrams every 4 hours. Yes? The max dose for Tylenol is 1,000. So they're usually 250 milligram tablets or 500 milligram tablets. So we would figure it out based on what we have. All right, but that would be how that works. Another example is if I were to give, the doctor wants us to give ibuprofen, 10 milligrams per kilogram per dose every 6 hours. Okay, and our patient's weight is 28 pounds. How many mLs will I give each dose? So I want you guys to figure that one out on your own. I'm going to give you a couple minutes and let's see what you come up with. What do we need to do first?
Convert.
Convert pounds to kilogram.
Yes.
Good. Okay, do that first. Put your kilograms into the formula and see what you get.
I want 27.
Do you want to round to tenths or hundredths?
We'll talk about that in a minute. You can
Okay.
put it in tenths for now.
I mean, are we converting the milligrams to milliliters?
Yeah, sorry, that should say how many milligrams, sorry.
Okay.
Oops. All right. So what did we get for weight? How many kilograms is he?
12.7.
13.5.
12.7.
12.7 kilograms. Everyone get that? Thumbs up? Okay. So if we're 12.7 kilograms, that's the number we are going to put into our problem, right? So we are going to do 10 times 12.7, and we are going to get what?
125.
127.
127.
Milligrams per dose. Now, did everyone get 127?
Yes.
Up. Okay.
Yes.
So if we all go, so now I'm going to tell you on hand, we have in the Pyxis, I have 125 milligrams per 5 mLs of ibuprofen. Okay. So if I need to give 127 milligrams per dose, I don't want you to answer. I want you to do the math, keep it a secret, and then I'm going to have you put your answers in the chat box. How many mLs am I going to give? So when you're done, put your answer in the chat box.
Do you want us to round to a whole number, the tenths, the hundreds?
Tenths, always the tenths.
Okay.
Yeah. Good. Good. The answer is correct, 5.1 milliliters. All right, so that's the basic math of pediatrics. So I'm going to clear this and we're going to do a couple together that are a little bit more in depth, okay? All right, so doctor prescribes. So DO is doctor's order, okay? Amoxicillin, 125 milligrams per kilogram per dose every 4 hours. On hand, so that's what we have in the Pyxis. We have amoxicillin, 80 milligrams per 2 mLs. Patient's weight, and this is what it might look like on your math test, okay? Patient's weight is 42 pounds, 2 ounces. How many mLs will you administer per dose? Okay, this is a multi-step problem. This looks scary, okay, but it's not. Okay, so we're gonna do this one together. All right, so what do we have to do first?
Convert the weight.
Convert pound to kilogram.
The weight.
Convert the weight.
Yes.
So, when we're doing pounds and ounces, what do we have to convert first?
2 ounce.
Ounce.
2 ounces. So what are we dividing that by?
16.
So we're going to take 2 ounces and divide that by 16, and we're going to get 0.125. Right? So now our weight after we do that is 42.125 pounds. Yes?
Yes.
And then we're going to divide that by what?
2.2.
2.2. Now remember, if you don't convert the ounces before dividing by 2.2, it's going to be incorrect. Okay, so I'm going to take 42.125 and I'm going to divide that by 2.2 and I'm going to get 19.147 kilograms or 19.1 kilograms. Okay, so that's the weight. So now I want to circle this because this is what's going to go into my problem. All right, so now what am I going to do next? What do I have to do next?
Dosage by weight.
So I'm going to put this into my problem, right? So I need to put this right in here. So I'm going to take 19.1 kilos. And I'm going to multiply that by the dose of amoxicillin, which is 125. And I'm going to get 19.1 times 125. What did we get? Milligrams per dose. Okay. Yes? Is everybody with me?
Yes.
Okay, thank you for answering. So now this becomes my desired. Okay, this right here becomes my desired. So now we have 2087.5 is my desired over have. Oops. And what do I have, guys?
Times over 125.
80 milligram per
Over-
2 ml.
Over 80 milligram.
80, yeah.
Times 2 ml.
Times 2.
2 ml.
So I'm going to do this math. I'm going to divide that by 80 times 2. And I get what? What was everybody's answer? In tenths place.
59.7.
59.7.
mLs.
Yeah.
Yep. So your answer that you would put on your answer key is right here.
Mhm.
Okay. That is pediatric weight-based multi-step. That's the worst it's going to get. Okay, I'm going to give you one to do now. Okay. So I want everyone to get a clear sheet of paper. Just check the chat box. Okay. I'm going to clear this. Is it okay if I clear this?
Mm-hmm.
All right. So doctor orders. Let me see. And I make this up. So gentamicin, 50 milligrams per kilogram per dose. hours. So this is doctor order. On hand, we have patient's weight is 22 pounds, 9 ounces. How many mLs per dose will you administer? All right, so go ahead and do this. Put your answer when you're done in the chat box, but don't say it out loud. We want to give everybody, yes, we're going to round to the 10th, even though in real pediatrics, we round to the hundredths. For the math purposes, we're going to round to tenths always, yes. When you're done, put it in the chat box. Now they're coming in, good. Bless you. All right. How did everyone do?
Okay.
So first thing we do is convert weight. Did anyone struggle with converting the weight? If you don't get the weight right, that could make the rest of your math wrong. Anyone want to share the 11.3s, what you did to get 11.3? Do you know where you might have made your mistake?
I just realized at first that I didn't convert to kilograms, but then
Yeah. Okay, good. Yeah, that's probably the most common mistake is that students forget to convert to kilograms. That will just mess up your whole your whole repertoire. Those that got 5.1, it probably was a rounding issue for you. That would make it wrong. So you need to be careful that you're always rounding to the 10th place, rounding properly, okay? Does everyone that didn't maybe not get it correct understand where they got it wrong? Okay. Now, I'm going to share one more thing with you. I'm going to put one more little crimp in it. If we have an order, so if I have an order that says amoxicillin 100 milligrams per kilogram per dose, per day. And then I want to give it every 6 hours. This is going to change the whole dynamic of your math. Okay. So if this word here says day, we will need to divide by however many times a day we're going to give it. So if you're giving it every 6 hours, how many times?
4 times. 4.
So 6 goes into 24, 4. So you're going to give it correct 4 times a day. So if we have amoxicillin and let's say our kid is 20 kilos, right? We would do 100 milligrams times 20 kilograms equals what? 2,000.
2,000.
Yeah, I should have been able to do that in my head. I'm just tired. 2,000 milligrams, but that's per day. We now need to take 2,000. We need to divide that by however many times a day we're going to give it, which is 4. And we would divide that by 4, and that would give us 500 milligrams per dose. Because we got to get it in the lowest form. Does that make sense? So one of the tricks that I tell students is if this word here says day, you got to divide. If it says dose, you're done. So DO dose, DO done. If it says day, you have to divide. So when you're looking at math questions, you always want to look. See how this one here said dose? And this one here says day. Make sense? Is anybody confused? Because the confusion are pretty present. We good? All right, so I'm going to give you one and see how you do. Okay. All right. I know it's a long day. Trust me. All right, so we're going to give clindamycin. We are going to give, and this is our doctor's order. So let me put that here. The order. Clindamycin, 90 milligrams per kilogram per day. I'm going to do every 12 hours. Okay. On hand, we have clindamycin. I know I don't think I spelled it right, but that's okay. 100 milligrams per 5 mLs. Weight is, I'm going to give it to you in kilograms just to make life easy for you right now. The weight is 52 kilograms. How many mLs per dose will you give? All right, do that one on your own. I'll give you a couple minutes. We'll see how you do, okay? You do it too. See how you're doing. Awesome. Is anyone still working? Raise your hand. Okay. Okay, I'll give you a couple more minutes. Good job. Christina, keep going. You're almost there. Now your desired over have times volume. You're almost there. Good job. Yep. How did everyone do with this one? Good. You have a question, Marie? Go ahead.
No, I said good. You said.
Oh, good. Awesome. Do you want to do one more?
Yes.
Yes, we do. Okay. All right. I'm running out of good ideas here. Hold on. All right. So we have, let's see, doctor's order. Um, um, all right. Have at that one. See how you do. Okay. Made it a little trickier. Some of you are super math smart. I love it. I was never math smart, so you should be happy for that. Elda, raise your hand. Yes.
I have a question, how you convert the weight to kilogram? This is where I got lost.
Yep, let's do it. So we have 5 ounces. We need to do 5 divided by 16, and we get 0.3125. I don't round until the end when it comes to weight. So then my weight is now 60.3125 pounds. And then I'm going to divide that by 2.2. And I'm going to get 27.4 kilograms. That makes sense, Elda?
Yes, I forgot pound the kilogram. Oh,
You can never forget that.
oh. Sorry.
That's okay. Don't be sorry. This is how we learn. No worries. Did anyone else struggle with any piece of it? Go ahead, Morel.
How come some people have 36.5 and some get 36.6? Because I was told that you don't round until the end of the problem.
So that was always how I was taught too. But you need to round when you do your kilograms as a separate entity. So let me see. So if I have 200 times 27.4, I divide that by 3, and I divide that by 50 times 1. I still get 36.5. So always remember your kilograms is separate. So when you get your kilograms, put that in 10th place first, and then do the rest of your math. Okay. I will say most likely in a multi-step problem, they're not going to make you convert during a multi-step problem. They'll give you things that say convert from pounds to kilograms. We used to do this and they said it was too hard. I don't think it's too hard. I think it's realistic, but I'm not sure they'll test you on it. I don't create your math test. It's done by the division. So I haven't seen it yet. So just know how to do that. But I think they'll probably give you kilograms for a problem like this. But if you can do it the other way, even better, right? Any other questions about math? So this is the gist with the weight base. That's really all it's about. This is as hard as it's going to get.
I have a question.
Yes, go ahead, Naomi.
Well, I just want to know where you got the 3 from when you divided the 5,480.
Because every 8 hours, right here,
Okay.
that would be 3 times a day. So remember, if this says day, you have to divide by however many times a day you're going to give it. Does that make sense? That help?
Yeah, I think I'm just thinking, okay, so you have to divide by the day before you even calculate before you even divide by the 50. Interesting.
Yeah. You have to have it in its lowest form. You want to have it in dose before you divide. I mean, before you do desired over half, correct. So if there's 24 hours in a day, correct, immaculate, you're going to divide 8 into 24 would give you 3, because 8 times 3 is 24. Make sense? So if it was every 6 hours, so like every 12 hours would be 2 times a day. Oops, what happened? What did I just do? Did I just unshare my screen? No, it's right there. So every 12 hours is 2 times a day. Every 8 hours is 3 times a day. Every 6 hours equals 4 times a day. And those are the most common ones you'll see. Okay. Any other questions, comments, concerns? That's okay. All right. So that's all for math. I'm going to pause the recording.